So when we are looking at dry eye and we are looking at the practical aspects of dry eye and we are seeing what is changing, I think pretty much everything has been covered by my prior speakers, but I'll emphasize on those which will be accessible to us probably in the near future. So what we are seeing in the market, it's not in the West and not yet come to us, is the availability of nasal sprays. The one such trade name is the Tirivaya, which is varenicline solutions, which is an FDA-approved medication for stimulating tear production, tear amusing. So it is one of the tear secretagogues here, which is probably can be used as a nasal spray to stimulate production of tears here. So that's something which is there, which is already being used by a few, but not yet accessible to us here. Punctal plugs, I think most of us do resort to using punctal plugs here. There's nothing new in it, but learning to adopt it in the right protocol during management of dry eye is perhaps particularly important here. So we do have punctal plugs which are called the temporary plugs and the permanent plugs. The temporary plugs are largely the collagen plugs, and these plugs will dissolve by themselves over a period of 12 weeks here. So these are probably going to be required on those patients of moderate dry eye disease here, where you will need to conserve the amount of tears which is already present in the conjunctival cul-de-sac. Do not want it to evaporate further. So requisite one is there should be some amount of wettability or tears in the ocular surface. Requisite two is that please rule out the amount of ocular surface inflammation present in the cul-de-sac before you're going to resort to this protocol in your management here. If you're using punctal plugs on an eye which is full of ocular surface inflammation mediators, it's really probably going to worsen the signs and symptoms of this patient, and this patient is going to be unhappy here. So such scenarios, a trial of temporary punctal plugs really helps, and you could observe how the patient behaves before you would take them on to a variety of, most of them are silicone permanent punctal plugs here, which you would like to adopt in your practice. So that's in a nutshell on how you would look at the protocol of engaging punctal plugs in the management of your dry eye practice. Moving on to step 3 is anti-inflammatory medication. So conservatively, we have used, or we still need to use a lot of surface steroids here. These could be potent surface steroids, or these could be less potent surface steroids here, but use them with discretion, and some of them might need a once daily dosage, especially the moderate to severe dry eye diseases and the specific type of dry eye disease patients perhaps can never get over the need for a surface potent steroid or a surface mild steroid in the management of dry eye disease. The various other anti-inflammatory agents, I think Anjana already discussed very nicely here. But one thing which I do adopt in my practice is I have started moving away from using cyclosporin to tacrolimus. Tacrolimus is a more potent immune modulator as compared to cyclosporin. The disadvantage being that it has a higher amount of surface irritation quotient as you would compare to cyclosporin here. So I have switched to using the tacrolimus ointment onto the lid or the lid skin surfaces of these patients. I use them mostly in those where you're going to need a prolonged immune modulatory therapy and to lessen their dependency on the surface steroids here. I do and now prescribe routinely tacrolimus 0.1% ointment. When you're using it over the skin, I give the higher dosage of 0.1%, and if you're putting it into the cul-de-sacs, it's going to be 0.03% here. So that does really help the compliance of these patients, and we did do a trial, a clinical trial where we used tacrolimus 0.1% on the skin of our patients in chronic PKC, and we looked at the tear tacrolimus levels in these patients, and there is a through the skin absorption of this medication, and really does increase the compatibility of use in those eyes where you do need to use immunomodulators for a long period of time. So that's something there. I will come shortly on in a few slides on what's going to be what's coming to us more in the terms of anti-inflammatory therapy and the use of specialized contact lenses. So these are a part of dry eye devices which we already know about. The pros is something which is too expensive and probably which is not affordable by a majority of our patients here, but we could very cleverly use the simply available mini scleral contact lenses. When used with a lot of care, does help in the ocular surface optimizations of those patients whom they need it. Dr. Anjana already covered lymphatic grafts, so I will not repeat the mechanisms, but some of you, if you're residents here or fellows, I think this is a very wanted or asked question in your exams here, or what is lymphatic graft here, what is its mechanism of action, what is ICAM, the nature of ICAM, and how lymphatic graft actually acts on as an ICAM inhibitor. I think if this is available to be read in most of your textbooks, so just sort of making an impression on you that you need to go back and look at it before you need to before it comes to us. We are hopeful that probably by next year we will be able to put our hands and learn more about how this works. But thus, again, this is going to need a minimum of 2 to 3 weeks before it's going to be effective here. Largely, I guess it's going to be acting very much similar to our cyclosporin therapy here. Targeted drug therapy is something what is being talked about in dry eye therapy scenarios now. So what do you really mean by targeted dry eye therapy? I think it was well covered by where you're looking at improving the surface secretion of the either aqueous or mucus, but targeted eye therapy in terms of targeting the ocular surface inflammation causative sources. That's what we have been looking at, targeted eye therapy here. And there are a couple of agents which have come into use, and these are available and can be accessible here. One such is the use of low-dose heparin, especially in dry eyes which have particular amounts of surface inflammation and which are refractory to management, as you have with ocular GVHD dry eyes and chronic Stevens-Johnson's chronic chemical injuries here. So low-dose heparin drops used at 100 international units per ml is supposed to have a good immunomodulatory or good surface inflammation control effect as well. And the concept of netosis, which means it's net traps, there's extracellular nuclear traps which are present on the surfaces of those eyes affected with chronic ocular surface inflammation, especially in ocular GVHD, especially in very severe Stevens-Johnson syndrome. I think this is a fantastic paper. This is led by the group of Dr. Sandeep Jain from India. He's based in Chicago here, and this is one of the unique papers which is there in latest research, which talks about the concept of netosis and the presence of ACPase, anti-citrullinated protein antibodies in the tears, which are responsible for the amount of refractory ocular surface inflammation which occurs in these eyes. So now therapy targeted towards these is going to result in better control of inflammation. So we have used ocular surface immunoglobulins made from intravenous IVIG drops, IVIG formulations, as ocular surface immunoglobulin therapy to control the ACPase on the surface, and the use of DNase drops is also going to control the net traps present on the ocular surface. So this is something new which is coming on which probably is into the clinical phase, and initial trials have shown promising results by using these therapies. So just an overview on dry eye devices here. So what we have, and I think is accessible to most of us in practice, though it is expensive, is the LipiView. After the LipiView imaging, you can use the LipiFlow, which are applicators which are placed on the lid to have a massaging effect, and that really helps in massaging helps to take away the clogged secretions here and also decrease the inflammation and provide relief. I do not use much of it in my practice, not in the mild and moderate. Probably there is a subset of patients who probably will benefit by the need of this therapy. Of course, it goes without saying that it is quite expensive for the single package for a particular patient here. And the IPL, or the intense pulse therapy, again is heat-induced stimulation for the blood vessels along the cheeks, and this is probably said to stimulate and help in the control of meibomian gland blockages, and some of them do have access to this, and it is being used as part of the dry eye suites in certain people here. But a simpler version is this premium eye spa, which comes at I think around 5,000 or 6,000. No financial interest again here. Can be bought over the net here, and this is like a simple eyelid mask which can be heated in your plugging it on into your USB ports. It's sort of an alternative to your lid massages, which you would hot fomentation lid massages here. But today I think if in your practice people are looking at something a little more sophisticated, they feel a simple massage, hot fomentation lid massage is something too inferior. But I think that works best, and I still do resort to it in most of my patients as well. This is something I picked up when I'm just returning from the Asia Cornea Society meeting at Thailand now, and this was one of the free paper presentations I listened to, and I was surprised to know that this is the Rexon Eye, which is available online here. This is another newer modality on quantum molecular resonance based release here, where it releases low power, high frequency electromagnetic fields for control of meibomian gland inflammation. So I think there are plenty of these which are coming into the market here. There was one particular paper which I did listen to, and they were quoting excellent results on using this, where you're not really using infrared heat or heat-related methodologies, but that using these electromagnetic fields to control meibomian gland inflammations. Yeah. I think Procera, many of us have know about it, and the cost precludes its inclusion in our practices. We do have several other similar systems, but I do not have experience on this. And I still resort to using mini-scleral contact lenses after optimizing ocular surface inflammations. And this is one such patient of very severe Stevens-Johnson's disease, as you can see from his ocular surface here, who benefits by not only visual rehabilitation but also by control of ocular surface inflammation. But you will need to keep these patients on very close follow-up, because these are ocular surfaces which are prone to several comorbidities, and you need to catch them on time before it's going to affect. But it really does help some of these patients who are affected with very poor vision because of the ocular surface disease. It acts as an ocular surface inflammation, ocular surface rehabilitator, and as a vision rehabilitator. I'll stop here and thank you.